Ladies and gentlemen, dear colleagues, my name is Martin Satny and I work at the Center of Preventive Cardiology, 3rd Department of Internal Medicine, 1st Faculty of Medicine, Charles University and General University Hospital in Prague. In the next minutes, I would like to draw your attention to Dyslipidaemias as a rare disease. Rare diseases are defined as conditions that affect fewer than 5 individuals per 10,000 people. Globally, up to 8,000 rare diseases have been identified, and together they affect approximately 300 million people worldwide. In Europe, an estimated 30 million individuals live with a rare disease, and in the Czech Republic the number is around 500,000. 80% of rare diseases have genetic origin, which also applies to rare dyslipidemias. Several lipid disorders fall in the category of rare diseases, each with a very low prevalence but significant clinical consequences if not recognized early and properly. There is a list of dyslipidemia that can be considered as rare. We go through each of diagnoses in more detail. First of all, I would like to speak about sitosterolaemia. Sitosterolaemia is extremely rare autosomal recessive disorder caused by mutations in the ApoBCG5 or 8 genes, with a prevalence of fewer than 1 case per 1 million individuals. Patients often present with a phenotype resembling familial hypercholesterolemia, but they typically do not respond to standard FH treatment and may even worsen with dietary interventions. These patients may also develop hemolytic anemia and thrombocytopenia. Diagnosis relies on blood count, LDH levels, lipids, and plant sterols, which can be measured by chromatography. Treatment consists of ezetimibe, an unhealthy diet low in plant sterol. Another rare dyslipidemia is familial chylomicronaemia syndrome. Familial chylomicronaemia syndrome has a prevalence of 1 to 2 cases per 1 million people. It's caused by mutation in LPL or its cofactors, but multifactorial or polygenic chylomicronaemia is more common. Patients typically experience recurrent episodes of acute pancreatitis. The risk of it is more than 300 times higher than in general populations. Symptoms often begin in childhood and may be accompanied by xanthomatosis. Diagnosis is based on laboratory findings and genetic testing. Treatment options include volanesorsen, fenofibrate, unfractionated heparin or insulin in acute settings, and plasmapheresis in severe cases. Lysyl deficiency, or morbus Volman, or cholesterol ester storage disease, is a lysosomal storage disorder with a prevalence of approximately 1 in 300,000 individuals. It's inherited in an autosomal recessive manner and caused by mutation in lipase gene. Clinically, it may resemble familial hypercholesterolemia, but patients typically also present with hepatomegaly, microvesicular steatosis, and elevated liver enzymes. Diagnosis is established through dried blood spot testing to measure enzyme activity, followed by genetic confirmation. The recommended treatment is enzyme replacement therapy with lipase alpha. Homozygous FH can be also included among rare dyslipidemias. Homozygous FH occurs in approximately 1 in 300,000 individuals. Patients usually have LDL cholesterol above 10 mmol per liter and develop severe hypocholesterolemia early in life. Clinical manifestations include tendon xanthomas and premature coronary heart disease. Diagnosis is confirmed genetically. Treatment requires an intensive multimodal approach that may include statins, ezetimibe, PCSK9 inhibitors, lomitapide, evinacumab, and LDL apheresis. Last rare dyslipidemia I would like to speak about is familial dysbetalipoproteinemia. FD has a prevalence of about 1 in 10,000 individuals and is typically associated with ApoE2E2 genotype, which occurs in 5 to 15% of cases, typically in other trigger factors such as insulin resistance. It's a highly atherogenic dyslipidemia characterized by mixed dyslipidemia with a total cholesterol to triglyceride ratio of approximately 2 to 1, low LDL cholesterol, and non-HDL cholesterol to ApoB ratio greater than 3.69. Patient may develop peripheral artery disease and palmar xanthomas. Diagnosis requires genetic testing and identification of metabolic trigger factors such as insulin resistance. Treatment consists of combination of statin and fibrate therapy. Prognosis of rare dyslipidemias depends largely on the age at diagnosis, the availability of causal therapies, and timing of treatment initiation. Although these disorders are rare, the presentation emphasizes that they must be actively considered in clinical practice, as early recognition significantly improves patients' outcomes. Dear colleagues, thank you for your attention. Greetings from Prague.